Good evening, everyone, and welcome to our webinar. This is the COVID-19 and IBD, What Patients and Caregivers Should Know webinar. And I am very excited that you all have joined us tonight, because I think we're going to get some really great updated information about COVID-19, otherwise known as coronavirus, if you don't know, which I'm sure you do, because that's all we talk about. And I'm really excited because I am joined by some of my favorite doctors from Central Texas. We have a nice wide variety of you on the panel, so I'm excited to have you guys join us. I'm going to do a quick introduction for our folks, and then I'm going to give you guys some logistical information here. Just as a note, I'm Alicia Barron. I'm the education manager for Texas, if you don't know me, and because I know we have some folks tuning in from elsewhere in the country. So welcome, everyone. Nice to meet you. I'm going to start with Dr. Thomas. Dr. Harry Thomas is a gastroenterologist specializing in IBD at Austin Gastroenterology in Austin, Texas. He is very active with the Central Texas chapter of the Crohn's and Colitis Foundation. He is the current chair of our mission committee, which is our educational committee for these types of things, and also serves on our leadership board. So thank you, Dr. Thomas, for doing both of those things. And Dr. Apurva Trivedi is right next to him, and he is a gastroenterologist, that's so hard for me to say, an internal medicine physician at Capital Gastro in Austin, Texas again. He has expertise in the management of IBD, Crohn's, ulcerative colitis, and C. diff. He is a member of the Austin Mission Committee for the Central Texas chapter as well. Also, not on camera, but joining us is Dr. Anish Patel, and he is also a lieutenant colonel as well. So he currently serves as the medical director of the Inflammatory Bowel Disease Center with the Division of Gastroenterology at the Brooke Army Medical Center in Fort Sam, Houston, and he currently manages the only IBD center in the U.S. military and Central Texas, and is formally trained an IBD specialist within the Department of Defense. He is the chair of the San Antonio Mission Committee for the Crohn's and Colitis Foundation. So welcome, Dr. Patel, and welcome and congratulations on your promotion to Lieutenant Colonel. And then joining us shortly will be Dr. Thuro Lakshman. He is a board certified in general surgery and colorectal surgery. He enjoys and practices all aspects of colorectal surgery, but has a special interest in minimally invasive robotic surgery, which is pretty darn cool. He has a special interest in IBD and is a member of our Austin Mission Committee as well. So thank you guys so much for joining me. I'm really excited to do this webinar and to hear from you all. Just quickly, some logistics. If you have, right now what we're going to do is I'm going to get myself off screen in a second, and Dr. Thomas is going to take over for me. And then after we get through all the slides, after everybody gets through all the slides, then we're going to open it up. We're going to do a quick little discussion, and then we're going to do some questions from the audience. If you have questions, you're going to need to type them in the question box. So in the GoToMeeting sort of navigation panel, you're going to see a box that says questions. You type your questions in there, and then I'm going to read them to the panel once we are done with the presentation. And then at the end of that, we'll answer all those questions, and we will wrap it up for the night. So without further ado, I'm going to turn it over to you, Dr. Thomas, and I'm going to pull up our slides. Everybody see the slides?
All right, well, thanks so much, Alicia, and welcome everyone. Thanks to my fellow panelists. I think this is going to be a great discussion this evening. I will start off with a few introductory slides and then pass over to my colleague, Dr. Trivedi, who will discuss in detail some of the medications we use in IBD and their potential relevance with COVID-19. And then we'll move on to Dr. Patel to talk about some of the other issues regarding IBD. And then finally, Dr. Lakshman is going to talk about some of the issues regarding patients undergoing surgery and who've had ostomies before the Q&A. So to begin, as many of us have heard many times by now, there are many types of human coronaviruses, and there are 4 that cause basically a significant proportion of common colds that we get from time to time. And what's different about SARS-CoV-2 is that it can cause significant morbidity and mortality with pneumonias and organ failure by really going down into the lower respiratory tract in addition to the upper respiratory tract. So in the bottom of the slide here, you see the nomenclature So the virus is SARS-CoV-2, and the disease it causes is COVID-19. You know, one question I had just in terms of semantics is, you know, when are we going to start calling this COVID-20 or even COVID-21? And one of my friends, who's an infectious disease doctor, explained that it's never going to change. The 19 is when it emerged, and that's basically what it's going to stay as. So I think that's all from this slide, so we can move on to the next slide, Alicia. So in terms of the symptoms, the predominant symptoms are, of course, respiratory with fever, cough, shortness of breath. But we have now an increasing recognition of the fact that a significant proportion of patients without pre-existing GI conditions can develop GI issues, namely diarrhea, nausea, vomiting, as a manifestation of COVID-19. And in fact, some patients have purely GI symptoms without any respiratory symptoms. One other important symptom to mention, which isn't listed on here, is anosmia, or loss of the sense of smell, taste, which seems to be, you know, quite a specific and sensitive symptom. It is also worth noting that the absence of fever doesn't rule it out. Although the majority of patients do develop fever over the course of the illness, only about half of patients have a fever at the time of presentation. So it's helpful, but not the be all and end all in terms of symptoms. So we can move on to the next slide. So in terms of precautions and prevention, this really is the most important thing, since of course we don't yet have a vaccine, we don't yet have, you know, any great treatments, although we'll hear a little more about those later. So really the key is prevention. And the foundation has outlined some of the key steps here. So washing hands frequently for at least 20 seconds with soap or hand sanitizer is obviously really important. Soap can basically disintegrate the virus and prevent it from causing additional issues. Keeping surfaces clean with disinfectants, since we know that fomite transmission is relevant. And then, you know, staying away from other people. So when outside, practicing social distancing. And this slide here says, if sick, wear a face mask. But, you know, of course, now everyone's recommended to wear a face mask really at all times, especially if indoors, because we know a lot of the transmission happens indoors rather than outdoors. Covering coughs and sneezes, and then staying home as much as possible, working from home if possible. You know, one thing worth noting is that, you know, we are used to providing letters for our patients who need to work from home or stay home from school. So don't hesitate to ask your provider for letters if they're needed by your workplace or school. And we can now move on to the next slide, and I will hand over to my friend and colleague, Dr. Apurva Trivedi, to talk about the IBD medication guidance.
Okay, thank you, Harry and Alicia, for putting this together and inviting me to cover this section. So, you know, the interface between inflammatory bowel disease and coronavirus is important. That's what we're going to talk about. The medications that we treat inflammatory bowel disease with are complicated, and there's many different classes. So we want to specifically talk about each in sequence. In inflammatory bowel disease, we recognize that the immune system is overactive or dysregulated. The body's not controlling the immune system. So in active inflammatory bowel disease, this manifests as inflammation in the bowel, either from the mouth to the anus in Crohn's disease, or predominantly in the colon with ulcerative colitis. And then there can be other sites of inflammation: the joints, the skin, the eyes can all have inflammatory manifestations with Crohn's and ulcerative colitis. So in terms of managing the disease, we have multiple therapies that modify the immune response that is dysregulated. And generally speaking, we think of these as lowering our body's immunity to infection. And the goal of the medication is to get the inflammation of Crohn's and ulcerative colitis under control. But as the lowered immune system is there to facilitate healing of the inflammatory bowel disease, this does, in some cases, put you at increased risk for infection. So next slide. Okay, so this is a busy slide, but it summarizes the takeaways for the various treatments that we have for Crohn's and ulcerative colitis. So the current recommendations regarding inflammatory bowel disease management, this was set out by an expert panel who met with the American College of Gastroenterology and the Crohn's and Colitis Foundation. The medications that we use for ulcerative colitis called the aminosalicylates, including Pentasa, Rawasa, Lialda, Delzacol, Apriso. These are non-immunosuppressing agents, so they will not impact you in any way if you're exposed to coronavirus. And so if you're solely on these agents, these are absolutely safe to keep taking through this time period where there may be more infectious exposure. So these drugs are primarily felt to work on the lining of the GI tract, and they do not immunosuppress. Then the next category here that we outline are immunomodulators. These are all pills that do lower the immune system in various mechanisms. Those include azathioprine or Imuran, cyclosporin, which is a Neoral or Sandimmune, mercaptopurine, which is purine ethanol, and methotrexate or tacrolimus, Prograf. These agents do lower the immune system, and our general recommendation is continue to take these medications unless advised by your physician otherwise. In most of these agents, there are detectable rates of increased risk of viral infection, but these rates are still very low. And generally speaking, if you're on this category of medications, your risk of having Crohn's or ulcerative colitis flare by stopping these medications is going to be much higher than your risk of having a complication related to infection. So again, immunomodulators, the azathioprine, Imuran, 6-mercaptopurine, methotrexate, continue to take those as prescribed. The next category, which is a very diverse category, is the biologics and the biosimilars. So the oldest category of drugs we have are the anti-TNF drugs, including infliximab, Remicade, and its biosimilar drugs, adalimumab or Humira, certolizumab or Cimzia, and golimumab or Simponi. These are all targeted immunosuppression that block certain pathways of the immune system. They do work throughout the entire body and have some systemic effects all through various organs, including the skin and the joints and the GI tract. Integrin receptor antagonist, natalizumab or Tysabri, or more specifically betalizumab, has been used more recently in ulcerative colitis and Crohn's disease. Betalizumab Entyvio is a very targeted immunotherapy for the gastrointestinal tract that limits immune cell trafficking to the gut. And in that scenario, Entyvio is felt to be fairly specific and does not generally, it's not felt to lower the immune system in the respiratory tract where COVID or coronavirus has its main effects. And the last category is ustekinumab, an IL-12/23 inhibitor, or Stelara. Again, Stelara is a systemic biologic, penetrates the skin, joints, and as well as the gut. So all of these category of drugs are lumped together as biologics, but each have their own specific mechanism of action and may or may not have slightly increased risk for immunosuppression in the setting of coronavirus. Specifically Entyvio, I think we would have a consensus that Entyvio does not lower the immune system in the respiratory tract. So these are categorized as immunosuppressive, and you should continue to take these. So again, all of these agents are indicated for moderate to severe inflammatory bowel disease. And if you have moderate to severe inflammatory bowel disease, and it took these agents to get your disease under control, then you should continue to take these, because withdrawing them absolutely will increase your risk for a flare. And that potentially we may not be able to use these agents again, because as biologics, we may develop antibodies against these and may not be able to use them again in the future. New on the market recently is tofacitinib, or Xeljanz, is a small molecule that inhibits the JAK-STAT pathway. It is, again, systemic immunosuppression. It's as a pill. It is immunosuppressive, and again, we do recommend continue taking these as prescribed. The next category is steroids. Again, two different categories within that would be systemic steroids, such as prednisone, prednisolone, or if you're in the hospital, hydrocortisone, versus gut-specific steroids, such as budesonide, Entecort, Uceris. These are considered to be immunosuppressive, and generally speak to your physician if you're on these. Stopping them suddenly can be dangerous. Starting them just independently without physician guidance can also put you at higher risk for complications, infectious complications. And generally, we as physicians taking care of Crohn's and ulcerative colitis patients try to avoid maintaining people on steroids and use the lowest effective doses. And lastly, antibiotics are used for various complications of disease, including metronidazole, Cipro, vancomycin, Xifaxan. These are non-immunosuppressive drugs, and you should continue to take these. Next slide. So another note about the steroids. Steroids are not felt to heal the underlying disease of Crohn's or ulcerative colitis, and they should not be used as maintenance therapy. They're not meant for long-term use. There has been enough data now in prior SARS outbreaks and in this SARS outbreak that show that absolutely steroids like prednisone do increase complication rates, such as needing to be hospitalized, being placed on a ventilator, or potentially even having death as a complication of infection for patients who are on steroids for their inflammatory bowel disease. Work with your doctor to identify, the lowest effective dose, or being able to get off of steroids to avoid these infectious complications, and also other long-term complications, including bone loss, osteoporosis, diabetes, high blood pressure, glaucoma, cataracts. So again, work with your physician. Don't stop them immediately, but do have a goal to decrease steroid use if you're requiring those. Next slide. We don't have a pediatric specialist on the panel, but there are children who have Crohn's disease and certainly are at risk for developing coronavirus. But the data is very good for young folks, young adults, and children. They generally have mild disease or are asymptomatic without any infection symptoms. But those folks can transmit the infection for weeks at a time. It does not appear that there's any higher complication rate in Crohn's and ulcerative colitis children with COVID. And we again recommend for all these children, if they required immunosuppressive therapy to get their disease under control, that they stay on those medications and follow the outlined guidance that Harry talked about in terms of limiting exposure of infection and appropriate hygiene to avoid contaminating their environment. Nutritional support is something that is used in pediatric population with either enteral feeds or limited diets, and those should be continued in this era, pandemic era. Next slide. Okay, I'll pass it off to Dr. Patel, who will talk about testing for SARS-CoV-2.
All right. Well, thanks, guys, and thank you all for attending. I apologize for the kind of camera angle. The 21st century technology beat me today, so I really do apologize. But really kind of I'm going to piggyback a little bit on what Dr. Thomas and Dr. Trivedi already kind of mentioned. So testing for COVID. Now, going back to what Dr. Thomas kind of talked about, more semantic-y, COVID-19 is the disease. SARS-CoV-2 is the actual virus. A lot of centers, I think a lot of the patients, you're going to notice, and a lot of endoscopy centers, and a lot of us will talk about this a little later on, whether or not you're going to get tested or not tested. There's a variety of tests out there. There's over, right now, the last count I had was over 40 tests that are available. Most ones in Texas are really going to be the SARS-CoV-2 test, which tends to be more of a nasal swab. The thing is going to be what that one's going to be is if you are positive and you don't have symptoms, there's a big debate, kind of what you do with these patients. Now, if you have positive testing and you have symptoms, meaning you have COVID-19, a little bit of separate category we put patients into. So I'm going to really kind of focus, really going to be on the testing aspect is who's testing, how we're going to test. Really, most systems across the board are going to do universal testing. A lot of hospitals are going to do it. It's going to be different on outpatient and endoscopy centers, and it's really going to be guided by your physician, your GI doctor. So I would tell folks to really have a good conversation with your GI doctor, whether or not testing is going to be available or they're going to do testing when it comes to actually doing procedures, coming to the clinic, doing endoscopy, infusions. Now, if you do get tested, now that's going to be a separate side of the house is if you do test positive on the nasal swab and you don't have symptoms, that's going to be a big decision between yourself and your provider, how you move forward. Really, most guidelines have kind of recommended, really expert recommendations have been that if you do have a positive test and you do not have symptoms, you do not have COVID-19, really on the right side is really the recommendations across the board is if you're positive with no symptoms, we do recommend holding therapy, whether it be steroids, thiopurines, methotrexate. We do recommend holding therapy for at least 14 days and then restarting after that, irrespective if you have symptoms or not. That's just a kind of general kind of guidance that that's been going across the board. And I'll tell you, in our practice here at San Antonio, we do practice that same methodology. But please do not stop the medications. Is just because you're positive or you think you have symptoms, don't stop until you talk to your physician. That's going to be the key kind of takeaway to this slide. Next slide, please. Now, if you develop it, okay, so now say you do have a positive test and or you develop symptoms that may be consistent with COVID-19. And the symptomology, a lot of people, you can actually go to the CDC website, and actually Crohn's Colitis has a great website looking at what potential symptoms could be for COVID-19. So what do we do? So say you develop COVID-19, what are the recommendations that come across the board? What we do with therapies? Really across the board, the first thing I'm going to reiterate it again is do not stop the medication until you actually talk to one of your providers. That's going to be really kind of key going forward, is that stopping unnecessarily can actually cause more complications than benefits in the long term. So kind of, I'm not going to read every single word over here. So I'm really going to focus really kind of on the bottom ones, which tend to be the thiopurines, immunomodulators, and the biologic therapies. Really across the board, if you develop COVID symptoms, immunomodulators, biologic therapies, we are recommending stopping it. Until symptoms go away, or if testing is available, if you test negative, vice versa. That's going to be the kind of the plan going forward, really, with biologic therapies. When it comes to your mesalamine therapies or antibiotics, they can still be continued. So we do not stop them, and your topical steroids. Dr. Trivedi, kind of came across this one with the steroids. So drugs like oral budesonide, topical rectal therapies, Euceris, those drugs you can still continue because the systemic absorption is very, very minimal in those drugs. So those don't be complication. But from steroids, immunomodulators, biologics, we still are recommending holding therapy if you do develop COVID-19. Next slide, please. Now, medication infusions. All right. So again, you're gonna hear kind of a trend I'm going to bring you across the board. Please don't stop until you talk to somebody. The reason I do it is because early in COVID-19, kind of early in the pandemic, we at our institution had a lot of issues with unnecessary stoppings and issues and questions that always came up. I always alert still, please do not stop infusion therapies until you talk to your provider. The biggest things, going forward with infusions is whether you go to your own GI clinic to get it done, you go to a private center, hospital, wherever it is. I do tell patients to take ownership of your infusions. Okay, you should not be, mad, or you should not be talk down to if you ask questions, to include, I mean, what kind of screenings are they doing at the infusion centers? Or do they have spacing? Are you allowed to have visitors? Do you need masks? Do you not need masks? These are very important questions, really harping on Dr. Thomas's one slide of how do you protect each other? How do you protect other patients? How do you protect your family? Is use proper social distancing. And infusion centers now do have mandates. I mean, a lot of them are going through across the board, are making them. They've done dry runs. I'll tell you, our personal infusion center at our hospital at Brooke Army here in San Antonio, we actually, I've actually went there with the tape measure and actually measured between chairs. We have great spacing. Everyone is mandated to have a mask. Okay, so we do not allow anybody into the institution without a mask. They actually, unfortunately, will be escorted out by security if you don't have it. So we do take it seriously. And also between patients, we do, with infection control's guidance, we do have proper infection control and infectious cleaning between the patients. Home infusion is a little bit different. Home infusions, it's going to be different, really going to talking to your home infusion clinic, home infusion service to kind of figure out what their plans are. So how do we monitor? Okay, so what are we doing for patients who say you're ulcerative colitis and you're due for your surveillance, you have Crohn's disease and due for surveillance? What are we doing with these patients? Now, obviously, we don't want to forego these patients. I mean, it's not like we're saying we're not important. Right now, a lot of centers, again, I know Dr. Thomas and Dr. Trivedi, and I'm sure Dr. Lakshman is also going to talk about this, is prioritizing. Okay, so now that Central Texas is going back to starting, is how we're going to prioritize patients. That's going to be based on each center. Every center is going to be different. Again, I recommend you have a conversation with your provider on how they're prioritizing patients, how you're going to be listed to get a procedure. We actually do have a priority list. There's a two GI staff panel who actually makes a decision kind of how we prioritize our patients. But when you kind of move further down, obviously patients with symptoms, you really do jump to the top of the list. I mean, you're not a forgotten group of patients. We actually do procedure. We're still doing procedure actively here. I mean, we actually have not stopped during COVID. We prioritize, and we kind of prioritize who we brought in there, but we haven't stopped. We do a lot of disease activity, staging and surveillance on patients who have symptoms. So it is a priority. But again, that's another conversation you have to have with your doctor. Don't just dismiss symptoms. Is always have a conversation with your doctor and let them dismay it, not you. Again, this is the reason these are in place. It's not, like I said, we're not forgetting the patients who need routine endoscopy or routine surveillance. We don't want to put you at risk, especially if you're on a biologic therapy and you're at your 12 years of UC and you're just on your every year or 2 year screening. You're still a priority for us. It's just that we don't want to increase risk for you to come into a center to have any complications from there, where we can also push you down the road a little bit when the COVID crisis dies down a little bit. All right, next slide, please. This is a big one. So this is one that, and I have the opportunity to have a fellowship here, here in San Antonio. This is a big one for me, is the emotional mental health part of it, which I have a lot of conversation with all IBD patients, is if your mind is not stable, everything else is not going to be stable, from family to disease and et cetera. So I actually do, and I personally, my wife and I personally do. My wife is a physician. We personally do this one. I turn off media. I stopped listening to NPR after a while because you just get the same old stuff was coming on there. CNN, all those things. I do take it off. I do turn it off. I actually do play a lot of games on my phone just to differest and kind of get away from stuff. Do develop plans. From meals to quarantine to medication, how you're going to get your drugs, who's going to go out to get drugs. A lot of stuff I also emphasize too is if you're one of 2 people in the family who have a disease and say you're on biologic therapies, I do encourage the opposite person, the spouse or the children, if they're of age, to go and do the shopping for you if they don't have any diseases or have any issues. Again, it's risk mitigation. I'm not saying you need to be a hermit and be in a bubble and stay at home all day. But a lot of this can be risk mitigation. But a lot of this can be too is if you have issues, if you're having trouble with depression, anxiety, you're having a lot of trouble with stuff, do not be shy to ask. Okay. A lot of stuff is we bring it up. Like I will personally bring it up in a conversation with my patients. So it's one of the first questions I ask during my virtual health appointments is, how are you mentally doing? How are you doing? From a mental health standpoint. I do routinely recommend and do refer to health psychology. We do have health psychology available here in San Antonio. Again, I'm sure Dr. Thomas and Dr. Shreddy could chime in and kind of get an idea of how Austin's market is. But I am not shy about sending people to get the help that they need. Allows us to be finding coping mechanism, being with friends and family. Again, friends is difficult, obviously, because we're in an area we have the social distance. But again, I will tell you, I just had a conversation with my friend in San Francisco who's been bottled up in his house, essentially on martial law in San Francisco for about 2 months now. So his effervescence is he FaceTimes me every week, and we just talk about just random stuff, nothing really pertinent to life or anything that we talk random stuff, and that kind of effervesces him. Do get out, exercise, get out fresh air, take a walk around the block, take a dog out for a walk, take your children out for a walk. I mean, I think a lot of stuff is a lot meant to be. I mean, Texas has fresh air. Okay, I train in New York City for IBD. There's not fresh air in New York City. I'll tell you. There's a lot of smog and stuff. At least here you get fresh air. Bringing in fresh oxygen is always a benefit. The other big thing too is this is a little bit of plug for the CCF. They have some great assets for patients. They have the IBD Help Center. They have great support systems. Facebook's been very good. Instagram, Twitter. There's a lot of stuff that support there for anyone who's available. Even providers. Okay. I mean, I know my nurse practitioner taking advantage of a couple of these things to kind of help her when it comes to managing these kind of COVID patients. So they're all assets out there, and there's always help available for you. So don't be shy to ask. Next slide, please. The other one is children. Obviously not going to really understand what's kind of going on. I have a 3-year and 1-year-old. Okay, they see mommy and daddy coming in and out of the hospital with a mask on. My son just asked me today as we're going to pick him up from daycare, is, Daddy, are you sick? It's the first time he's ever asked me. I've been wearing a mask now for 2 months. So it is. We've had conversation with both of our children. The 1-year-old doesn't understand a lick of anything. At least the 3-year-old is starting to understand. So we do have conversation with our children routinely, saying it's for protection. I think it's very paramount to have the child, the children at least have some sort of semblance of ideas. The other big one is going to be too is the older children. All right, so I will give you, and I won't go on too many diatribes. I apologize, but the one thing I had was I had a patient whose daughter was in college, decided to go on spring break during the middle of the COVID crisis, and my patient was on a TNF inhibitor. So her daughter came back and started having symptoms of COVID. She actually tested positive for COVID. The first thing I told my patient was, take your bags, go to your mother's house, 2 hours away, and stay away from your daughter. Again, it's a life learned, is that you have to counsel you and your older children to use common sense. Okay. I mean, that's going to be the big one too, is just because you have the disease, you also have to let the children know is that it can affect you. These silent carriers is the big one that's kind of coming around. So having a big conversation with the children and your other family members too is very paramount. Next slide, please. And again, so people like us, like myself, Dr. Lakshman, Trivedi, Thomas, any of us can get IBD also. Okay, so I have a lot of my colleagues. I mean, I have a lot of doctors in the hospital that I manage who actually have IBD. And the questions about you can see the laundry list of questions that always come up when it comes to being an essential worker and having this disease. Again, Dr. Thomas and Dr. Trivedi kind of re-alerted to this one, was that if you feel you're at risk or have issues, reach out to your provider. There are memos, there are letters we do provide. I've really been a big advocate of teleworking. Things like this. I mean, we're on GoToWebinar. I mean, I think things like this kind of platform, if you're able to do it from a work standpoint, I do highly encourage it. If there's a workplace issue where you can't do it or you have concerns, the rules when it comes to engagement of supervisors and workers have become a little more lenient. So actually, I have been able to get people a little bit off work in order to have if they're at risk. So just take advantage of it. I mean, if you have concerns, please provide it, bring it up to your health provider to get an idea of whether or not you're at risk or not. Next slide, please. And there's a lot of research. Okay, so I'm not going to really hash a lot of it. We'll be here for another 4 hours if we go into all this one. So, but anyone can go into this one. So Secure IBD is actually done by one of my good friends at Mount Sinai. They actually put together a registry. So this is an international registry. So any provider, anybody can put in a patient that they have COVID and IBD together. Right now, I actually just looked at it before I got onto the webinar. There's at least 1,000 patients now listed on the registry. So it's great insight. There's a lot of webinars they're doing now. I think they just had a patient webinar coming up here soon to kind of get an idea of what the data shows when it comes to COVID and IBD. There are all trials coming. Okay, drug trial, Dr. Thomas kind of alluded to it. Dr. Trivedi also alluded to it too. There's a lot of drugs out there. Okay, I mean, you can hear the news and one drug was touted over another. I mean, there's drugs coming. For this. Again, nothing mainstream yet, but there are drugs. Vaccination is also the same way too. I mean, these are two areas that are a big need and a big promise coming out of the pipeline. Next slide, please. All right, and this is a little plug. If you want to learn a little more, if you kind of forgot things that we all talked about, I know Dr. Lushman is going to kind of come in here in a second, talk about surgical aspects of stuff. But if anything, there's myself, Dr. Thomas, or Dr. Trivedi talked about, and you don't understand anything or had any idea or any questions about it, please go to the website. The website is actually very good and very easy to kind of understand things from a standpoint. And please ask questions too today. This is a great opportunity to ask any questions you have for all four of us here. I'll hand over to Dr. Lushman now.
Great, thank you, Dr. Patel. Thank you for having me, Alicia. My name is Theodore Lakshman. I'm a colorectal surgeon here in Austin, Texas, and I appreciate everybody taking their time this evening to learn a little bit more about IBD and this sort of COVID pandemic that we have going on here. Instead of boring you guys with slides, I thought you'd let you all look at all of our handsome mugs for the next few minutes. And I'm going to just talk briefly about surgery and IBD in the setting of COVID here. I mean, it's a whole nother, talk about the indications of surgery for inflammatory bowel disease, and that's not really, I think, the point here. I think is to sort of touch on some important points in the relation to surgery in general as it relates within this current pandemic that we're having going on here. So I think it's one of the important things to note is that this is everything is an evolution, and it's sort of a constantly moving target in terms of acuity and resources available and number of cases and hospital resources and all those things. And all these multiple factors can affect also how hospitals determine how surgeries are going to be conducted in this setting. So that being said, focusing on Texas and the Central Texas region, we've been looking to sort of, recommendations and guidance from both the government and also from a national level as surgeons. We look to the American College of Surgeons and the American Gastroenterology Society and other things like that for some guidelines to follow. Utilizing the American College of Surgeons guidelines, there's basically sort of three phases in terms of COVID preparedness or COVID acuity, phase 1, 2, and 3, getting from phase 1 is sort of in the early phases where there's still resources available, the hospitals are not overwhelmed, and then 2, when it becomes more of an issue, more limited resources, and then 3, when it's an emergency, when all resources are being utilized for COVID. And I think it's safe to say that Texas has done a relatively good job so far of helping to sort of flatten the curve and maintain our resources well. Here in Central Texas, the major hospital systems have done a good job of identifying specific facilities that have been sort of set aside, particularly for COVID, at least now, once we've got a better handle on what's going on with the situation in this region, so that other hospitals can start to work sort of as they regularly would. And so in that vein, I think currently where we're at right now is that the hospitals are opening up for more elective surgeries. In the several weeks and months prior, basically only emergent surgeries were being done, and none of the elective surgeries were being allowed to be done. But that's changed now, and we're slowly starting to ramp up and do more elective surgeries. So what that means for us as IBD providers and for you as IBD patients is that patients that are requiring surgery for IBD now should be able to get those done. Now, that doesn't mean everybody rushes out to the hospital to get their colonoscopies and their fistulas managed and things like that. I think we still have to exert some significant precaution and cautions here when we're thinking about this. So I think to keep it simple, there's some very hard and fast indications and contraindications for surgery for IBD anyway. You know, as a principle, as a colorectal surgeon, we're always sort of taught to avoid surgery if you can, and manage all the best, you know, utilize all your medical management resources from my colleagues and friends here in the gastroenterology world first before going to surgery. This is particularly true for our Crohn's patients. We know for ulcerative colitis, there is a definitive surgical treatment with a total proctocolectomy, but ideally you can do that in an elective planned setting. But even for Crohn's, it's best to wait until there are specific complications, i.e. Persistent bleeding, perforation, toxic colitis, strictures resulting in obstruction, development of fistulas. I'm sure all these terms are familiar for a lot of the Crohn's patients out there in the audience. But those types of things that would require surgery are things that we would still be able to get done in this current setting. Now, if you're able to manage some of these problems, medication changes, sort of intermediary measures, and avoid going to the hospital, I think that is still your best bet if it's safe and it's not worsening your condition. Because there's still the possibility of there being COVID patients, both diagnosed and undiagnosed, in the hospital. And in a generally immunocompromised state with inflammatory bowel disease, you put yourself at greater risk of infection by going into a place where there's multiple frontline workers. Here in Austin, we've designated certain hospitals where the majority of the COVID patients have gone. So there are other hospitals you can go to where there'll be less exposure potentially, but we can never know for sure. So I think we follow the normal sort of common sense guidelines. You have emergencies that need to be done, then obviously that has to be taken care of. Perforation, toxic colitis, bleeding, those things I mentioned before. You start having more of these gray areas of things, you know, persistent smoldering abscesses that require anorectal surgery, medically refractory ulcerative colitis. I think this is something where you have a frank discussion with your gastroenterologist and your surgeon. You identify a hospital that is a non-COVID identified hospital, and what sort of delineates that is that also you have to make sure that we're not utilizing resources that need to be saved for potential COVID surges as well too. And so you can identify a hospital where you can get this semi-elective procedure done. Other elective procedures, if you can hold off, I would still hold off because there's likelihood of another surge coming up, at least if not in the next few weeks or months, in the fall or the winter as well too. In terms of what to do for the prior to the surgeries, if you do need to have surgery done, it's very important that you get tested for COVID, particularly if you're having major abdominal surgery. There's data and some papers coming out of both Europe and China that have shown patients that have undergone major abdominal surgery, particularly GI surgery, while infected with COVID and having COVID symptoms, have done significantly worse with higher incidences of complications and mortality as well too. We do know that the virus is shed, the viral RNA is seen within feces as well, and within intestinal contents. So there is a good possibility of increased exposure to other healthcare workers, but also dissemination of the virus as well too. Also, when you are in the operating room, a lot of the sort of things do get aerosolized because we're using coagulation and heating elements and things like that, very similarly to like they may have mentioned before with endoscopic procedures. So it's very important that you get tested beforehand if you are planning on proceed with surgery, particularly major abdominal surgery. The systems and protocols vary from hospital system to hospital system, and even from hospital to hospital. Most of the hospitals will have a screening process that undergoes for major surgeries. You'll actually have to get a test done. If you're getting outpatient procedures like endoscopy or outpatient anorectal surgeries, then there'll be a screening process, and depending on what that particular facility decides will determine whether additional testing is necessary or not. But given the fact that there is a component of asymptomatic carriers out there, and also the increased risk with immunosuppression in our IBD population, I think it's very important to know and to get tested if there's any question. Really, I think from a surgery standpoint, that's really it. I think that I would say that in general here in Texas, we're well prepared. We're reopening in terms of elective surgery. That has been going, for the past couple of weeks now. It seems to be going well. I've been operating on my IBD patients. A few cases we've started to do now. So those are there. I just think it's very important that we exert the right amount of caution beforehand, and then make sure that the surgery is necessary and not something that we can't wait on. So I think at this point I'll turn it back over to questions. Alicia.
Hi guys, yeah, thank you so much. This was very informative, but I do know these slides were prepared by our National Scientific Advisory Committee and not necessarily y'all. So I am curious if there was anything that was not included on these slides that you think is really important for our IBD patients to know. So Dr. Thomas, I'm going to start with you since you're in my top corner.
Yes, thanks, Alicia. You know, I think we covered a lot of great points. One thing I will add on to Dr. Patel's discussion, his last slide was about patients who have IBD who themselves are in high-risk occupations, which includes not just healthcare workers, but other frontline workers, you know, grocery store employees, for example. You know, this can be a difficult situation. And one thing that I've come across personally, having a friend who's on Humira, who's a healthcare worker who got furloughed by his employer, is I want to mention that, you know, the Americans with Disabilities Act has pretty clear information stating that, you know, patients or employees should be given an opportunity to discuss with their employers before unilaterally furloughed. So if you as a patient have concerns about completing your day-to-day tasks in your job, certainly have a discussion with your healthcare provider, but then have an actual discussion with your employer. And if you are in a situation where you're furloughed without really having a chance to discuss, you know, it is something to take up with HR departments. I think this is happening, and you know, the Crohn's Colitis Foundation does have some great information on the website that, again, Dr. Patel pointed out, and has additional resources if anyone has had you know, trouble in this regard.
Dr. Patel, anything from you?
No, you know, the slide deck is very comprehensive. I mean, I've actually gone through it several times before in the past when it actually first came out. You know, I think the biggest one is really kind of takeaway in general. I mean, you know, really doesn't really harp on the slides. Is we're still not out of, out of the danger zone. Dr. Lakshman actually just brought it up. I mean, you know, there's still a risk that we can have a second bump come up, you know, here in the next couple of weeks to months, depending on how we go. So I will tell patients, I encourage my staff, my patients, my wife and I do it ourselves, is still take the precautions. Okay, don't take it lightly. Just because the government, just because Governor Abbott or, you know, the president or whatever it is says, you know, open door, we can go and party on the beaches with 1,000 people. We're still not in a danger zone. You know, the numbers are still increasing. You see it. I mean, we have 100,000 deaths of COVID as a couple days ago. So I would harp on it. I think the slides really don't harp on the complexity of this pandemic, but also the severity of what can happen. I think that's the biggest one to kind of take away from it in general.
Dr. Trivedi, anything else that you want to bring up?
Yeah, I think shared decision making about management is important, and the way that I approach all these discussions about, you know, drugs and escalation of therapy and you know, what sort of preventative actions we should take is first off deciding what is the individual's risk of acquiring this infection. So are they in a high-risk environment? Are they frontline workers? Or are they people who could completely work from home, don't have household members going out and working in hospitals? If that's the case, then, you know, I counsel them that we can be aggressive with a more aggressive management approach because they're in a low-risk environment for acquiring the disease. If they are in a higher risk situation, then we have a conversation about, okay, if I put you on combination therapy with an immunomodulator and a biologic for your disease, and you want to work as an emergency room nurse, we have to have some some give there. And these are decisions that have to be really fleshed out, and I think you have to really have a detailed conversation. And so the way that I structure it is high, intermediate, low risk of exposure, high, intermediate, low risk of complications of the disease. So if you're an older individual with underlying lung disease and you need more aggressive immunosuppression, that's absolutely a higher risk category. If you're a 20-year-old who works from home and is socially isolating, that's a low risk individual in my book. But that's a conversation that has so many factors about behavioral patterns and underlying other diseases that you really have to have that conversation with your physician. And there's not going to be a single answer for everyone. We can't just rubber stamp everyone.
Very true. Before we get to the questions, because we do have a couple that I think are great, but I'm going to start with mine, the prerogatives of being in charge of the webinar. So Dr. Patel brought up the secure IBD registry, and I'm curious, that has been going on for a little while and has had pretty robust participation. So I'm curious if there's anything specifically of note that you guys have sort of garnered from that data that's coming in from that secure IBD registry. And y'all can jump in whenever you feel like it on that one.
Yeah, so the I'll start. I actually had a conversation with Dr. Ungaro about a week ago. He actually sent me some of his PowerPoint presentations that he did on the actual registry. So I think the biggest takeaways, I don't think for many of us, it really surprises us that steroids are a big risk. They cause more complications with COVID, and also having more opioid use. People being on chronic opioid therapy does put a risk. But the interesting fact was, and kind of what we saw in the registry, was that being on biologic therapies actually did not significantly increase the risk. I think that's the one kind of safety measure you want to take away from the. I mean, it's a registry, so you have to take it with a grain of salt. The data is going to be a little bit skewed, and it's going to be very, very minimal what we get. But I think the biggest takeaway when I had a conversation with Ryan was that the biologics actually did not. We were concerned about it. I mean, a lot of us were concerned about it. I'll tell you, from the beginning of when the COVID started, I was freaking out about the TNF inhibitors, the biologics, the immune modulators. Like, oh, this is gonna be really bad. I had to put everybody in the bubble and not let them leave. But the registry is really showing us it doesn't change. And there might be some protective benefits. And there's some data, case series and reports coming out of the TNF drugs, and so it might be protective for COVID. So I think that was the big registry takeaway. I think it's a phenomenal thing they did. I think it's great. I mean, it's not just IBD. I mean, the registry is for everything from liver to other disease states. And I think this is a really good kind of thing where the community, I mean, it really shows the community comes together. I mean, IBD community is coming together from an international standpoint to really kind of get a grasp on this and get an idea of who's at risk and who's not at risk. I think it's a phenomenal registry.
I agree, and I'll just add, as a patient, if you yourself are exposed and have the virus, obviously you're going to be in touch with your team, and also ask them about, having your details uploaded to the system. Of course, it's all anonymous and secured, but as we get additional data, we'll know a lot more. And just like Dr. Patel said, it's actually really been amazing. I mean, just over the last couple of months, how much data we've accumulated, and now we can be fairly reassuring and confident when we give advice to our patients, as opposed to just being in a situation where we say we don't know. We can actually provide quite a bit of reassurance about almost all of these medicines.
I think it actually makes it a little bit, I mean, not super, but a little bit more comfortable with starting people. I think that was the big takeaway I got from the registry when I talked to these folks, is that it's not as fearful as a provider to put somebody, to start them right off the bat with like a TNF drug. Just like Dr. Trivedi said, I mean, you obviously prioritize your patients. And that's obviously key. And what Dr. Lushman said also is you prioritize, what are they risk of surgical complications or not surgical complications. I think the registry does help us. I think it gives us a little bit a little eye-opening, saying that you don't have to shy away from biologics. You don't have to keep everybody who's got fistulizing Crohn's disease on mesalamine because you're scared that TNF might hurt them. I think it really does help. I think from a diagnostic and from a medicinal standpoint, it does help us a lot. I think it makes you more comfortable personally. with that coming out. I don't want people seeing Dr. Lakshman if I don't have to. That's what helps me. No offense.
None taken.
Thank you, guys. All right, Dr. Trivedi, I'm going to send this question to you. It says, if an individual presents with only GI symptoms, i.e. no respiratory symptoms, would a nasal swab test be able to detect the virus?
Yeah, so there's, I'm not as expert as, I'm not an infectious disease specialist, but so there are, there's a number of different assays out there. So there's a molecular assay which actually detects viral RNA, and that's the RT-PCR rapid PCR test that's had been taking 24 to 72 hours to turn around. Abbott has developed a device that is giving you basically bedside results from a swab within 10 to 15 minutes. The reported accuracy of these is supposed to be about 80 to 99% specific is what they report. The nasal swab is done because that's where the virus is felt to be easiest to access and most concentrated. But we certainly see that the receptor, the molecule that the virus binds to is called the ACE2 receptor. It's present in throughout the GI tract, in the small intestine, the gallbladder, the large intestine. And so viral particles will be throughout the entire body. So the virus, if it's detected in the nasal swab, is presumed to probably be the cause of the underlying GI manifestations as well. And about 40 to 60% of individuals with the virus will have some diarrhea. The virus seems to shed for 2 to 3 weeks in the diarrhea, in the stool. So that once the fever is gone, once the respiratory symptoms are gone, there's still a potential that you can be shedding some virus, and that can be a pathway for infection potentially. So, the question I think was, does the nasal swab correlate with the GI symptoms? That's the method that we're using for most patients. And then the last method, the serology, which is the antibody development, takes about 2 weeks after resolution of infection to develop. And so that's going to be a poor marker for active infection.
Yeah, I think it's a great question. I'll just add that I've definitely heard of a number of cases just like this where patients are repeatedly negative on their nasopharyngeal PCR. And in the research setting, we can do PCR on stool material, but that's not regularly available clinically through, any of the offices or hospitals. So there are situations like that where it might be quite difficult to get diagnosed, and it may not be until weeks after where you get a serology or antibody test that's positive that you are able to diagnose it in retrospect. That can be a challenging situation.
I'm going to ask you guys a follow-up question. This is my follow-up question to this is, there are GI symptoms that come along with this with COVID. And so I'm curious if there's a way to, is there any way to see if whether the GI symptoms you're experiencing are related to your IBD versus coronavirus, say COVID?
I was going to say simple no.
I assume that was the case, yeah.
Yeah, I mean, this is no different than having, you're really well controlled on whatever therapy you're on, and then you end up having diarrhea for a couple weeks. I mean, is it related to something you ate or something you did, or is it from the disease? And this is a tough one. I mean, we battle with this one a lot. I mean, I always see heads nodding for all the guys over here. I mean, this is a tough question. I don't know. I mean, a lot of times, you do the judicious workup like you always would. You get appropriate stool studies, make sure it's not something we're missing, like a different virus, different bacteria. We really kind of do it. We actually do non-invasive inflammation testing here down in San Antonio with fecal calprotectins. People who persist, I don't think it's unreasonable to consider an endoscopy if we need to. But yeah, there's no flat, easy answer saying is it that or is it not. I don't know. I don't. Maybe Dr. Thomas Trivedi, Dr. Lakshmi can maybe give me a better answer than I had of just no. But it is tough. It is a very tough diagnostically to kind of figure it out.
Well,
Yeah,
I think it's a moving
absolutely.
target, though, is the problem,
Yep.
is that we're
Yep.
learning new things every day. I mean, in January, the symptoms was a dry cough and a fever, and now there's like a list of about, you know, 10 to 15 different things you can have, including, like Apurva said, about, significant GI symptoms. And so you also have to take in that I think we're still trying to learn about the biology and chemistry of the virus itself and how it affects our immune system, which therefore can affect IBD patients significantly more. So I think we're just going to have to keep watching and waiting and learning. Sorry, Harry, go ahead.
Oh no, absolutely, I agree, and it kind of relates to the previous discussion. Since we're not readily able to test for the virus in the stool, there's a lot of conjecture and retrospective diagnosis making going on with GI manifestations of COVID.
I was going to chime in that there is that one scenario where if the patient presents having had diarrhea for over a month, at that point, potentially the patient has a serology, an antibody to COVID, if that was the underlying trigger. So, but they could be true and unrelated. So you can have COVID and have a flare, it may be that COVID was there as the initial inciting event, and that viral infection has now put you in active, Crohn's colitis flare. So if you have a serology, we think that's protective, but that's not been proven. And then the other wrinkle, unfortunately, in our patients is the body produces antibodies with a robust immune system. And if we're modifying the immune system, if you're on high dose steroids, immunomodulators, potentially we're not going to see the same antibody production as you would in an intact immune system. So it's still a very dynamic field right now.
Yeah,
Just to
I know.
piggyback,
I asked you a hard question. Sorry.
the only thing I'd add is just to piggyback on that from a surgical standpoint too, is that it may be difficult to know with a modulated immune system, if you're on immunomodulators, what your testing is going to look like. So I think it's that much more, or what your symptomatology is going to look like, and if it gets mixed between, is it COVID, is it my Crohn's flare-up? And I think that's very important when you're at a point where you're considering surgery, because you're almost effectively an asymptomatic carrier because you think it's your Crohn's, but it could potentially be COVID symptomatology, and then you're exposing healthcare workers or facilities to that too, which is all the more reason to get tested before, consider whether the procedure needs to be done with a frank discussion with your surgeon and your gastroenterologist, and then make sure you get tested appropriately.
Okay, we've got a few questions that came in specifically around sort of kind of returning back to the real world. So this person is wondering, they have a child with Crohn's disease who's taking Pentasa only, and so they're concerned about going back to school when and if this is possible. So I'm going to let anybody take that who would like to.
Yeah, I mean, listen, I mean, the risk is low. Just kind of, we had a couple of slides here before, even if you got COVID-19, on mesalamine therapies, there really is no increased risk of having COVID problems with it. I do encourage it. I mean, people, like, especially, I don't do pediatric GI, so I can't really relate to school age children, like younger kids, but my college age kids, I mean, if their schools are starting and they're on a mesalamine therapy, I do encourage them to go back to school. I mean, I think part of it is that, and we see with the registry too, with mesalamine therapies don't increase the risk of COVID complications. Again, proper distancing, proper stuff. I mean, that doesn't change. But I'm not anti them going back, and actually, you're really kind of getting the social aspect of it back. Again, I don't block them.
I would, again, this is a low-risk individual on a low-risk medication, and you could say that there's an intermediate risk of going back to a college environment or even a school environment. So if the community prevalence, if you know that your community is a relatively low rate of infection, which we have predominantly in Central Texas, the prevalence rate is actually very low, then I would say that, being out in public with appropriate social distancing and hygiene, that's a low risk individual in a low-risk environment. So I would give them a green light.
I agree.
All right, this person's question is they're on a biologic and they have to go back to work, but they're going to be around a lot of people and they're not able to social distance. Gloves are not required. And so any thoughts on this person going back to work?
Yeah, so for people who are not able to work from home, we are able to provide some reassurance based on the data from the Secure IBD registry, as well as other countries around the world, in that they're not at significantly increased risk of acquiring the infection. And if they do get exposed, they're not at increased risk of worse outcomes. So basically, I would say in that situation, it is okay, follow all the usual precautions. The one caveat is if your disease, your symptoms were to flare and you ended up needing to be on prednisone, then that does put you in a higher risk category and would need to reevaluate. But for just biologic therapy in and of itself can be reassuring in that regard.
Yeah, I agree, Dr. Thomas. I mean, this is going to be based on our area. It's a little lower on the risk, but again, proper precautions there too, irrespective of what the company does or wherever it is. But again, if you can, if your job can allow for teleworking, I still do encourage it. I mean, even now that we're opening up and kind of doing stuff, if you can allow teleworking, I actually do encourage it. And I actually do. CCF has a great canned memo that providers can use to kind of help people go to teleworking, and we've done it. I mean, I have a lot of patients that are on still teleworking that have encouraged to still stay teleworking because, again, just like Dr. Lushman brought up, I mean, we don't know what's going to happen in a couple of weeks. I think encouraging the proper distancing. And if you can't really do it, then a lot of this is going to be is you taking your own proper precaution. If you have to go back to work, I would never stop somebody from going back to work. But is you wear your own, have your mask, have good proper hand hygiene. If you can try to distance yourself, people are sick around you, get away from them. I mean, you really kind of common sense kind of stuff. I think that's why I would encourage people who actually have to get back to work and don't have the precautions in place with it. And again, just like Dr. Thomas brought up, the American Disability Act does protect people. I mean, if an employer rightfully or unrightfully, terminates you or you have issues with that one, there is protections in there, and then new protections came in there because of the COVID stuff. So there is protections there, just to be aware of on that one.
Okay, a couple other questions here. So we have somebody who's also on a biologic, and they're curious if they need to get tested prior to going in for their regularly scheduled infusion.
So that's going to be very dependent on locations. That I always encourage people, ask your provider. I will personally tell you, at our center, we are not testing people. We just do a questionnaire. So we actually there's a lot of good data out there, and actually the infectious disease folks have published great data on this, that a simple questionnaire and actual proper distancing, you can actually get away with not having to do a test. So we at our infusion center, we are not testing people coming in. Now, if you're symptomatic, having fevers, any issues or anything going on, we are delaying it. We leave it on the patient, but we do a call 48 hours, 24 hours before the infusion to see how patients are doing. So we actually proactively will ask them. And the day of, we do a temperature check, and we actually test your oxygen levels in your system. If either of them are abnormal, we actually will not do the infusion. We actually we'll send them home and tell them, and we'll reschedule within a week or two later. But again, proper distancing, that kind of stuff, we encourage that one, but we're not testing.
Yeah, absolutely agree. I don't.
Absolutely. I'm not aware of.
Go ahead, Harry.
Oh, sorry, Karen. I was just going to say, I'm not aware of any infusion centers that are requiring testing prior to infusions, but certainly all infusion centers, as well as offices, endoscopy centers, are screening patients, meaning asking the questions, screening questions, checking temperature, sometimes oxygen levels. And then the policies regarding testing prior to endoscopic procedures really depends on the facility that you're going to. And so you'd need to check about that.
And So I would just chime in that again, the particular biologic matters. If you're going in for an Entyvio infusion, that's a very, very low risk drug. And it appears that even the anti-TNFs are very low risk. The prevalence, if you're going for an infusion in New York City, I would say that that's a different conversation than if you're going into an infusion in Waco or San Antonio. The centers are cognizant that they're treating very sick, immunocompromised patients. It's not just our patients that they're treating neurologic diseases, they're treating rheumatologic diseases, and they're very careful and cautious. So, and they're following up with these patients and making sure that no one's coming up with infection, and they can do contact tracing and determine if any other individuals were exposed. And you want to have that conversation with the nurses in charge ahead of time. I think that would be important to do, just become comfortable, but I don't think testing every individual is necessary.
Great, thanks guys. All right, Dr. Lakshman, this question is for you. How long after surgery are you suggesting patients stay isolated, or what specifically are you recommending for your patients?
After surgery? So as long as the patient is tested negative, which they should have done prior to the surgery, I suppose there's a potential exposure for being in the hospital. I would probably recommend a week worth of isolation, which would be your sort of regular recovery time too. Again, some of this depends on what's the surgery they had done and the setting that they had it done in as well too. An outpatient surgery center, it's going to be a little bit less volume, a little bit less patient traffic. The risk of exposure is going to be less, and then also assuming that everyone there has been tested and/or screened, like we talked about before. So I think you can follow sort of normal isolation protocols that you would anywhere else. The decision for isolation is if you think that you have been exposed, to prevent exposure to others, or if you're concerned in your immunosuppressed state of healing that you're going to be at a greater risk for exposure. I don't think there's a hard and fast answer on that. I would say that, so for post-surgery, I'm not really exactly sure, but at least several days if it's major abdominal surgery, particularly if you've been on immunologics or biologic agents too, and there's some concern about exposure. For prior to surgery, I think it's important that you're essentially isolated or quarantined for at least 4 to 5 days prior as well too, just to make sure that you're not having any exposure before. And then that gives you about that week's worth of time from exposure to symptomatology onset, which we were, generally seeing.
Great, thank you. All right, so this question is a little more specific. This person is on a biologic and also a prezo. Probably said that wrong. And they, because of their circumstances, must send their child to daycare in order to work. So they're curious if there's, are you advising anything against people sending their children to daycare? Dr. Trivedi, I'm going to start with you on that one if you have an answer.
I'm in a similar situation with 2 kids at home, and as a lot of us are, and childcare really has become a much more complicated situation with the quarantine and pandemics and children staying home from school. What we know right now is that there's not been any real large-scale outbreaks of COVID amongst school children. We've seen that in concentrated environments like nursing homes. We've seen it in prisons. We've seen that in cruises. But part of this is children could get exposed and be asymptomatic. But generally speaking, I would say that the child as a vector of this is going to be if we put everybody back in school or everybody back in daycare, then those children can circulate all sorts of infections. We know that happens seasonally. But daycare, for this woman or man who has to take these medications, you have to decide, is that something that enables you to go back to work and maintain your finances? And if you don't have a job, are you going to lose your insurance and lose your ability to maintain your your therapy? So it becomes a very complicated matrix. So I would say cautiously, the best advice is try to limit the concentration of individuals that you're interacting with or your child's interacting with. So if it's a daycare with 100 kids in a same building versus 7 kids in a building, is the 7-kid environment is going to be safer. That child, if there's any fevers or outbreaks in the facility, that they're going to need to be careful. But we see this with flu outbreaks, norovirus outbreaks, giardia outbreaks. The kids will be spreading these things, and they may not be symptomatic, which makes it difficult to know what they're bringing home.
Yeah, I'm going to piggyback on that one. So actually, both my children are both in daycare right now. My wife and I are both healthcare workers. So I think one of the big questions I would ask, also kind of piggybacking what he said, was make sure the daycares have proper protocols. You don't have to necessarily worry about the children; it's the workers. So you have to worry about, because they're adults. A lot of them are adults. So a lot of daycare, you want to make sure they're they're following proper, if they're wearing face masks, proper hand hygiene. I mean, our personal scenario for us is every time we go in and out of daycare, we have to use antibacterial, antiviral things, and we have to wear masks. We're mandated to wear a mask in and out of the daycare. All the daycare workers are mandated to wear a mask when they're indoors with the children. So they have the proper protocols in place. We secondarily add more stuff to us. I mean, when the kids come out, we actually we have more sanitizer in our car. We sanitize them. When they get home, we actually change their clothes and put them in the wash. I mean, we're probably a little bit more type A than some other people would be, but as long as you take the proper precautions, I don't think you're at increased risk with daycare. It's gonna be really more of your interactions with who's at the daycare. I think that's where my bigger concern would be, not necessarily children, it's gonna be who's at daycare, and use the proper precautions and make sure they have the proper precautions in place for it.
Yeah, I think great points by Dr. Trivedi and Dr. Patel. I would just say that there's a lot we actually don't know about children and this virus, the disease, daycare, schools. But out of everything that's come so far, having lived with this for almost 6 months now, I don't think that this individual who's on the biologic needs to keep their child or children home necessarily.
Okay, great. Thanks, guys. So now this is, that's all the questions from the audience, but I'm going to ask one that I think they're probably all wondering, is we've seen some discussion of medications to treat these diseases that have come out in the news, things like hydroxychloroquine, and also the new medication, oh gosh, hang on a second, I looked it up a second ago. Remdesivir, that one. So I'm gonna throw that your way and have you say, like, the one that's mentioned the most, the first one that got mentioned was the hydroxychloroquine. So can tell me a little bit about what research is showing on that one. Dr. Trivedi, I'm gonna start with you. Oh, Dr. Thomas, you start. Perfect.
So almost every drug under the sun is currently being studied to see if it might also be effective against coronavirus, and hydroxychloroquine is something that's been around for close to 100 years. There was a lot of interest in it as an antiviral, but really the sum of the evidence today, which has been a huge number of studies, is not really showing that it is effective against the virus. And in addition, it does have a known significant risk of cardiac disease, specifically potentially fatal heart arrhythmias. And so the evidence has really come out against that. There is another antiviral medicine called remdesivir, which we are getting some more positive data about. However, this is currently an intravenous medicine that has to be administered in the hospital. So if you've been diagnosed by your doctor's office or in an ER, this is not something that you can take at home unless you're admitted to an actual hospital. It again is not the be all and end all. It does hasten the recovery and improve some outcomes, but we're still interested in potentially combining it with other medicines to really make it more effective. There are many other trials ongoing, but right now that is probably the more effective one that's come out so far.
Yeah, I mean, harping on what Thomas just said, I mean, there's tons of studies that have come out so far and multiple different therapies. I mean, we have some HIV drugs, there's chloroquine. I mean, more recently, there was a big study, I think it was a European study, they got their hydroxychloroquine arm actually got halted because it actually caused more complications. The Chinese study showed that there was a benefit. That's where it really kind of got hyped up at. But then tons of studies have come out so far saying that actually might be detrimental. But really, I think hydroxychloroquine is really out of favor. We have to understand these therapies, just like Dr. Thomas said, it's really going to be for the hospitalized patients. It's going to be what drug can prevent them from getting worse in the hospital, hopefully getting them off of vent if they're on a vent. We don't have anything right now looking at if you pop positive on like a screen as an outpatient and asymptomatic, can you take a medication to prevent it? We don't have that. That's really where vaccinations come from. This is really going to be is prevention. It's going to be how can we prevent it from even happening. I think that's where the big one's coming from. I think vaccines are going to be number one. I wouldn't even put on my list therapies. That's really going to be for the sick of the sick. And hopefully nobody on this panel is listed. I would never hope and pray on anybody to be in that scenario where you need a medication, hope and pray for one. Really, it's going to be prevention. Vaccines have been number one. I think trumping the question, I don't mean to trump the question, but I think really it's going to be is can we get a vaccine? I think that's really going to be the one moving forward, not necessarily therapy. I don't think we're ever going to get therapy because we don't even know who has it. Because the testing, like we mentioned and we've already mentioned, is the testing really accurate? Not, it's not really. I mean, most of these tests are the sensitivity, like how much can you trust a negative test? We can't really trust a lot of it. So that's a big moving target. I think vaccines are going to be number one. Medication therapy is going to be more for the sicker ones, personally.
That was going to be what I was going to dovetail into, is that as we go forward, this is going to be something that we have to really encourage all of our patients, whether you're on immunosuppressants or not. Once we are, ready with a vaccine, please get vaccinated. Please get vaccinated. That's applied for our inflammatory bowel disease patients, generally speaking, for influenza, pneumonia, meningitis, pertussis. But this is going to be one of those. It's just going to be an absolute. We want everyone to do preventive therapy, so we're not having to scramble to decide what to do when you do get sick.
All right, we had a question come in, and this is a good one. So could someone address the possible use of immunomodulators or immunosuppressive drugs to treat the that are thought to result from the cytokine storm? So.
Oh yeah. Well, so part of the whole thing with cytokine storm, I mean, this is where the theory of using like a drug like a TNF or a JAK inhibitor, that's the theory, is that why they may be quote unquote protective is because of that reason, because they might be preventing a cytokine storm compared to immune modulator. Really sick, the immune modulator, we still didn't really know why they work and how they work in IBD. I mean, that's still a big debate between multiple experts of how it really works. I mean, TNF drugs and more biology, you kind of have an idea how they work, and that's the theory, is why they're protective, is that they might be preventing that storm from happening when people develop COVID. That's why maybe protecting them from more severe complications. They're not going to prevent COVID, but it can prevent more severe complications. That's where I think a lot of the theory and a lot of again, it's all theoretical. I mean, I don't have hard data science on this one. It's all theoretical, and I think that's where a lot of that's coming from, is that it might be limiting or minimizing cytokine storm when you use those kind of drugs.
Can I back us up just a minute, and can one of you explain what the cytokine storm is?
I can leave that to whoever else wants to. Right.
Yes, so there is a lot of variation in how this virus causes morbidity and mortality. Early on in the disease, it's mainly due to the actual effect of the virus on the lung tissue. But later on, days into the illness, we believe that in some individuals, the majority of the morbidity is actually being driven by inflammation, driven by the patient's own immune system rather than the virus's damage itself. And that is because of a number of cytokines or molecules released by different cells in the immune system, which can be at such high levels that we sometimes colloquially refer to it as a cytokine storm. The main anti-cytokine agents that have been studied so far against interleukins 1, beta, and interleukin 6, but there is interest, as Dr. Patel mentioned, in studying anti-TNF agents, so the ones we're all familiar with. And there have been some case reports actually of patients with IBD and COVID then getting treated with anti-TNFs for the first time and doing better, but they are anecdotal reports. We don't have great evidence yet, but we're looking forward to those data.
Anything to add, Dr. Trivedi?
No, I think they summarized it very well. There's mouse data at this stage with using anti-TNFs to limit SARS-induced lung injury. That's the level of data that we have. We don't have definitive data in humans, and the immune system in humans and mice is going to be different. But I think that these large registry studies do indicate that the biologics, at least are neutral in terms of, risk, and there is potential that they could show that they're protective.
Great, thank you guys so much. Any final thoughts, because we're getting towards the close of this webinar, so any final thoughts from any of you?
One thing I'll just add is about vaccinations. So obviously we're all eagerly anticipating some news about an effective vaccination against coronavirus. But one thing to remember when having your routine visits with your IBD providers is we do currently have some effective vaccines against infections that we know are increased in patients with IBD, including influenza, pneumonia, and so it's really a great opportunity to get those if you haven't already had them. So do bring it up with your IBD provider if they don't mention it.
Yeah, I think a lot of takeaways are going to be is we're going to get through it. I mean, it's kind of more of a sloppy kind of story. Is this is going to end? Okay, it may take months to years, but it's going to happen. It's going to come to an end at some point. A lot of stuff is we're not out of the woods yet. I think it's be safe, be protective, be smart. I think that's one of the key things. Just because things are opening doesn't mean you got to go to it. With that one, so I think it is be precautious, be safe, and have conversations. I mean, you should not be faulted or have a problem talking to your provider and asking questions. Even if they're dumb questions, doesn't matter. Ask them. If you want to ask it through the patient portal, because you don't want to feel dumb doing it in person, ask it. Okay, there's no dumb question. A lot of stuff is going to be is our jobs. Myself, Dr. Thomas, Dr. Trivedi, Dr. Luchman, is to really make it comfortable for everybody. Is to make it where our job is to treat your disease, okay, and make it safe for you to kind of go out there and give you a quality of life. That's the whole goal, okay. So don't be afraid of leaving, but be safe when you kind of do it. Life will come back.
I think that's a good point because, one of the things they've talked about, both in the meeting we've seen here, is that the incidence of like heart attacks and strokes and those visits to the emergency room in the hospital has dropped significantly. But I can guarantee you those the number of cases are still the same. It's just patients are afraid to go in. I mean, I know personally of a case of my friend's father who lived in the Bronx and was in a nursing home and was scared to get him into the hospital, and lo and behold, A, he had COVID, B, he developed a blood clot, and C, ultimately required an amputation. And that was simply from being afraid to going in. He was afraid to go into the hospital for fear of getting COVID. How that relates to us and our IBD patients is your fear of contracting COVID resulting in a worsening flare-up that could lead to toxic colitis, and then, like Dr. Patel said, seeing me instead of one of your gastroenterologists in the middle of the night is not a situation we want, So if there's a concern or there's a question, your IBD is just as serious an illness as COVID is. I think that's an important point to make. So, just be careful and prudent, but don't be afraid to ask questions and act on something if you think you need to.
Yeah, that would be my takeaway, is that this is going to be, again, more shared decision making. There's probably a lot more room for doing more activities in Texas than there are in other parts of the country, but you have to be cautious. Don't be terrified that there's COVID on every surface, but the takeaways would be be cautious, wash your hands, have conversations with your healthcare providers, and when something starts to change, talk to us.
Great, thank you guys so much. My one final thought for me, so I want to thank you guys so very much for doing this webinar. It really was, I think, very, very informative, and it was nice to have all of your voices. It's good to get the differing views. What I want to do finally before, as we wrap up, is I just want to invite everybody to join us. We do have some opportunities to still engage, despite the fact that we're all at home and with our dogs and husbands walking in. We want to still engage with you in opportunities like this, educational opportunities or web-based opportunities, but also we have a really fun opportunity coming up, and on June 20th, we're doing a virtual Take Steps walk. So we're going to have a lot of things happening on our Facebook pages. We're going to have really great patient stories and different speeches and things like that happening there. And you can still have an opportunity to get that sort of community feel that we typically have as part of those Take Steps walks on June 20th. So I do want to invite you to participate in that event, because it's a really fantastic way to get to know some of your fellow Take Stepsers across the country, and to still raise some awareness and some funds for the Crohn's and Colitis Foundation. So love to get you involved in that. Take a look at that on our Facebook page. The other thing is, if you're parents of children with these diseases, we are doing virtual Camp Oasis. And so please do send your kids to me for virtual Camp Oasis. It's going to be a summer-long activity schedule that we have, as well as a week that's specific to Texas. So if you're interested in that, please email me back, and I'm happy to give you some more information on that. So we have a few things happening for the foundation as well. So again, thank you guys so very much, and thank you all for joining us tonight. And I hope you all stay healthy and well, and so take care. Bye, everyone.
Thank you.
Thank you.
Thanks, guys.
Thank you all.
Appreciate it.